If you like this challenging case, then you can also go to the challenging cases playlist where you can test your clinical skills by diagnosing many different challenging cases of ophthalmology. Now, challenging case 35 was really a difficult case because without history given, I also would have diagnosed it exactly as most of the viewers diagnosed it. As the picture was bilaterally similar with multiple opaque white spots all around the cornea, mimicking corneal dystrophy. So my top differentials would have been map dot fingerprint dystrophy, Reese buckler dystrophy, macular granular or lattice stromal dystrophies. But look closely and think you have seen number of corneal dystrophies. Does it matches exactly any of the above mentioned dystrophies? Well, my answer will be no. Map dot, Reese buckler, they are superficial, and though they can make such shapes but are not that much opaque and are lighter in shade than these lesions. Granular have a specific pattern of breadcrumbs and intervening clear spaces, and macular is the most near differential accurately mentioned by Dr. Arshad Mahmood. But if the lesions were present since birth and there was no history of a chemical installation, I would have gone with the atypical appearance of the macular dystrophy. But this patient had something accidentally gone into both eyes, and after that, this appearance occurred, mimicking dystrophy. Now, these are also superficial opacities, and why these are formed? Well, first we will go that what kind of chemicals can cause corneal opacities. Well, the chemicals we have got acids as well as alkalis and other chemicals. Now, acids, how the acid cause the corneal injury? Acid dissociates into hydrogen ions and anions in the cornea. Hydrogen alters the pH of the cornea, while the anions causes protein denaturation, precipitation, and coagulation. Now, protein coagulation creates a barrier and thus generally prevents deeper penetration of the acids and cause ground glass appearance. But this is not a ground glass appearance. Alkalis penetrate deeper because they dissociate into hydroxyline and cations. In the cornea, hydroxylines saponifies the cell membranes, fatty acids, while cations interact with stromal collagen and GAGs, glycosaminoglycans, that interaction facilitates the deeper penetration through cornea into the anterior chamber. So alkalis are more dangerous than acids. But here these atypical white opacities, they are superficial. You should also know the domestic products that contain these alkalis and acids so that you can act accordingly. But now look at these opacities. We all have managed hundreds of acids and alkali patients in emergency and not once encountered such appearance. So it's not an alkali or acid burn down. Now what is it? Well, when I asked, the patient gave me the history of hot cooking oil splashed into both eyes, resulting in these multiple bilateral superficial corneal thermal burns or heat burns. So for anything which enters into your eyes, whether acid, alkali, or boiling oil, rinse your eyes with tap water. Your first response should be irrigation of the eyes for at least 15 to 20 minutes. You can use normal saline if it's available or if you are near the hospital, and then rush to the ophthalmology eye care professional. Now, as this was a superficial thermal burn, I gave this patient antibiotic steroid ointment at night, artificial tears, Nepafenac drops, and antibiotic drops during the day. The patient had severe photophobia, so I gave him sunglasses, and I advised him bed rest, and asked him to come for the follow up after a week. Now, usually, these opacities, superficial opacities, will disappear as the new epithelium grows down under. So, hopefully, you must have learned something new, and now you can differentiate between the dystrophies, the chemical bonds,